I'd like to present a case which illustrates the use of a single Vectra value and how that may be interpreted with relationship to care of the patient with rheumatoid arthritis. This is a 46-year-old female with seropositive RA who was seen by another rheumatologist about 6 months ago and was started on low-dose methotrexate and low-dose prednisone. And because her insurance company changed, she was referred to a second rheumatologist who was seeing her for the first time. Her exam at that time showed 4 tender and 6 swollen joints, and the patient complained of about 45 minutes of morning stiffness. The clinician obtained an initial Vectra value at 46, was at the low end of the high range. This patient also had a normal CRP, and normal CRPs and normal SED rates are seen in up to 2/3 of patients who have elevated disease activity, indicating that they're not particularly useful for monitoring and assessing disease activity. In this particular individual, who has an anchor value of 46, and that test result was obtained after several months of treatment with methotrexate and prednisone. So we don't really have a true baseline value. But that value in the high range associated with the clinical findings of tender and swollen joints indicates that this patient, although she may have benefited to some extent from the traditional starting of low-dose methotrexate and prednisone, still had active clinical disease. And despite a normal CRP, by her Vectra test, she has high disease activity. And the implications is that this patient should either increase her methotrexate or be considered for a biologic, because after several months of conventional therapy, she still has evidence of active disease clinically and has evidence of active disease from a molecular perspective.